It is now my great honor to introduce Professor Haruhiro Inoue. I think he is somebody who doesn't need an introduction. He is the current president of the Gastrointestinal Endoscopy Society in Japan, and he is the director of the Showa University Hospital in Tokyo. And Haru will talk now to us about the challenges of third and fourth space endoscopy using the new features of the X1 processor. Please, Haru.
So thank you very much, Stefan. Your introduction to me. So congratulations, great success again of the course of the EndoSwiss. So please, and you also now you have the XZ1200. It's a series of X1, so it's a very good, so high definition and also brightness you can get it. Okay, so please start my lecture. Hello everyone, thank you for this opportunity and congratulations, Dr. Stefan Siewald. Great course. It's my great honor to join and a pleasure to join this EndoSwiss. So I would like to talk about the EVIS X1 and the ESD and the beyond technique that include ESSD. So background of installation of X1 is like that. So this is New York. New York, they use the US, they use the EVIS 100 series. And Paris in France use also 100 series. And here in Zurich, Stefan and the Hughes Random Clinic use the 100 series. It's a nice endoscopy unit. And the England EVIS 200. Japan and India is a 200 series. So when we think about the globalization, unification of endoscopy platform is important, double to single. And not only unifying the platform, we need to keep or make advance in a high quality image. So simply, I can say, when I first use the X1 new platform, I feel the brightness and also a high resolution image, which also covers a multiple IEE, image enhanced endoscopy platform. So this is the actual X1 image when we perform ESD and the submucosal dissection, like this. Beautiful image. And the EVIS X1 new endoscopy unit has the three different image enhanced technology. First, I would like to introduce the TX1. TX1 and NBI for detection of the mainly early cancer, and the EDOF NBI, it's a kind of a magnification NBI, it's a tissue characterization. And the during treatment to see bleeding point well is the LDI. So this is the white light image. When we start the examination, the patient pharynx looks like this very nicely. No blind area, so very clear endoscopic view. So this is a TXI in the esophagus. Using TXI, we can emphasize the superficial vascular structure and the mucosal surface pattern very well. So this is a TXI demonstration in the stomach. Left side, you can see a conventional white light, and the right side, you can see TXI. We can recognize the fold are vividly well contrasted image. Oh, so blue arrow indicate the large polyp, and beside right side we can recognize a very tiny polyp. So two polyps together. And then so behind, please note behind this large and tiny polyp, behind it we can see a TXI image. Small polyp here. Yes, this one. But in our NBI white light and NBI image, we cannot recognize the small one. Okay. So like this way, TXI works well. So next, the NBI. NBI is used to be, NBI was dark. But now you can see a very bright image like this, bright view. So this is a duodenum, or we can see surface pattern much better in NBI. So this is a case demonstration early esophageal cancer, squamous cell carcinoma. So conventional white light, this is X1 image. Anyway, so blight, and we can see 12 o'clock direction, we can see some mucosa erosion. Now we advance endoscope a little bit. Anyway, so TXI, we can see the coarse mucosal surface much better. And NBI also works well to see the vessel pattern. You can see an abnormal vessel in a brownish area. Then we can say there is some high-grade dysplasia, squamous cell, early-stage squamous cell carcinoma spread the surface of the esophageal wall. Then we perform the ESD like this way. In this case, we use a TTJ knife. Okay, so this is the very end of the procedure. Some part is here. We perform the muscle dissection because of the fibrosis of the submucosa. But anyway, so using XI, bright light, we can see our esophageal lumen very well. Next, I'd like to show you the case of early gastric cancer. You can see erosion, the gastric antrum. So NBI, we can see abnormal vessels like this way, and combined with EDOF, we can see magnifying image. Yes, now we switch to our NBI EDOF. Then we can see a very nice magnifying image. You can recognize red blood cell movement of the surface oozing. Okay. Next, I'd like to demonstrate the LDI. So this is a bleeding from the mucosal cut end. So in LDI, red blood looks yellow, and it looks like a bile. And then we can, so most important is switching to LDI, transparency of the blood increases. Then we can detect relatively easily the bleeding point. This is a bleeding at the time of full thickness resection of the gastric gist. So at the time we encounter bleeding, the subserosal layer, then so we switch to our LDI. The blood looks like a bile, and then we can see our bleeding point much better. Then using coagulation forceps, we coagulate it and stop bleeding. Then now we're coming back to white light. So this is once again. So breathing point, it's very difficult to point out. But switching to RDI, we can see our breathing point is here. Then we can apply a coagulation forceps on it. Yeah, then coagulate. It works. So this is a case of endoscopic subserosal dissection. This is a very small, but this is a gastric cyst. Then we have to remove this tumor. So in this case, now we are dissecting the muscle fibers connecting to our cyst tumor surface. Yeah, we scoop up the muscle fiber and then cut it. Yes, like this way. Scoop the muscle fibers up and then cut. So now we can see, we continue, but anyway, we can see the bottom of our curtain, we can see a peritoneum. So this means we can successfully preserving the peritoneum. So reason why I can say this is a peritoneum, behind we can see a movement of the pancreatic surface. So like this way. Like this way, EBS-X1 is very good to use in a clinical practice. So unifying two scope platforms, and they keep using a very high quality image, 4K, and a bright light source, and a simple manipulation for magnification. That is the EDO. And the various image enhancement technology. So NBI is the most famous, and the TXI, and particularly LDI works well during when we manage the bleeding, covering all aspects from detection to tissue characterization and finally treatment. So this is my message in this presentation. Simply say, so new X1 platform has actually big impact because, so simply, it's a very bright vision and the high resolution image and the multiple image enhanced technology. So thank you very much for your kind attention.
Thank you, Haru, for this interesting lecture. You nicely guided us through diagnostic endoscopy to therapeutic endoscopy. My first question is, do you think that the endoscopic therapeutic procedure times will be reduced with the new system?
So, Stefan, thank you so much. It's a good question. Good image. It's good to evaluate. For example, early stage cancer, we can evaluate the lesion split, particularly margin of the region, border of the region, clearly using the scope. So in such a meaning, may reduce time, but I think not to directly change the examination time or therapeutic time. I talked in RDI. So when we encountered this RDI system was the first reported by Dr. Yahagi. So first he said, so RDI works well, but I'm not sure. But so last few cases, actually I encountered bleeding. At the time, RDI works very well. So without RDI, so sometimes very difficult to identify the bleeding point. But using RDI, switching to RDI, we can quickly identify the bleeding point. So that's quite helpful to control the bleeding. It may reduce the procedure time.
Okay, another question is, you have nicely demonstrated the TXI, NBI, but my question is, a regular diagnostic examination, you would still start with the white light?
Thank you very much, Stefan. It's a very important question. So, particularly squamous esophagus. So we may use NBI as a standard light source. Used to be we use a white light, but it depends. So I myself very familiar with the NBI image. So in the area of squamous, so we use squamous esophagus. We use NBI, and so current X1 has a very strong light source. So even in a stomach, so NBI not magnifying. So NBI it works. So we can detect the region well contrasted, and sometimes looks brown, more brownish compared to the background, contrasted to background. So potentially, so bright light source makes the NBI application of NBI much easier.
Thank you. Michael has another question to you.
Yeah, Haru, thank you so much for the lecture. It seems that that the future will be brighter, and we may even change the blood into amber right now. But my question reflects the potential application of TXI for the dissection and therapy. So do you think that TXI, by enhancing the texture, can be helpful to differentiate or navigate through fibrotic tissue and better differentiate from the muscle layer? This is for us Europeans much more difficult as for you, Haru. So how do you envisage that?
Aha. So it's a very nice question, Dr. Kaminsky. So your good point. So I myself have no experience to apply TXI during ESD. So Yahagi-sensei, do you have experience to use a TXI during a submucosal dissection?
I only have a few experience using TXI for submucosal dissection. Actually, we can enhance the fibrosis, but sometimes it becomes a little bit too much. Therefore, I still prefer to use white light during submucosal dissection, especially for the water pressure method, which we usually dissect the tissue under water condition. Then we can magnify the target lesion. Therefore, I prefer to use just underwater condition using white light. That is much better for me. And of course, we should use some blue dyes to visualize the submucosal layer. That usually helps so much.
Thank you so much. I'm not the moderator, but so he answered very well. So Dr. Kaminsky, so you point out a very important thing. So I would like to apply TXI during ESD myself. I will try. Thank you.
Thank you so much.
Thank you, Haru. It's very nice when we give you inspiration from our meeting. So thank you very much for your outstanding presentation. And I pass now back to Michael.